on Lakeview Gardens. This will allow everybody here to air their
Concerns.
comments.
Yeah.
And-
Do we just speak from here?
Yes,
Okay.
please.
I have
Could
a,
you identify
I
yourself and then stand?
I have a, pardon?
You don't need to stand. I don't need to stand.
Yeah, I probably can't do that today, Stan, unless you need to have me do that, and then I will try. I'm Lori Crocker, and I was going to come last month, but I missed the meeting, so I apologize for that. But I wanted to be on the agenda, and they very kindly put me on the agenda, because I have some concerns. First of all, what I really want to say is, I personally, and I'm sure all these people here, we need long-term care here in Lakeview. We need it. And so there are some things that I have some ideas about. And what can we do to help you fix it? What can we do to help? That's my message. And because we need it desperately here, we do. And this is my third go-around with utilizing long-term care here in Lakeview. And so I appreciate the opportunity to get to speak. But I have three major concerns. And the overriding everything is safety, you know, and then the resident care, and then sanitation. Another one is probably, those are my three major ones. But communication with the families is very important. The fifth thing I have is a staffing suggestion. And another point that I really would like addressed or have some information on is long-term care's relationship to the emergency room situation and the policies regarding the health issues of the people in relationship to their diet and, you know, things like physical therapy, occupational therapy, and so forth like that. And the staffing, appropriate staffing in both of the cottages. And finally, I really would like to address in the end what I perceive, I'm not speaking for anybody else, as respect from the hospital side of the hospital to the long-term care nurses and CNAs. So let me begin by saying that I really, really feel that there needs to be a full-time nurse 24/7 in each of the cottages. This is an accident and a big lawsuit waiting to happen if that does not happen. Because there are times when a nurse is needed and a two-person assist is in another room and so forth like that. I think a lot of problems that I see could be solved with that. And I think for the price that the people are paying, and I'll just speak from, you know, I have private pay, and it is horrendously expensive. I don't know, I would have sold my soul to take care of my husband. I would have done that. And my mother and his father and whatever it took, I would do. But we say we want to have good care, but we need a full-time nurse 24/7 in both buildings, and this would solve a lot of problems. Another concern that I have is that we are expecting too much of the CNAs. The CNAs are trained to be compassionate, to work with the resident care. They have not had housekeeping 101. They have not had laundry 101. They have not had environmental sanitation 101 to be expected to clean bathrooms and so forth. And any time that their time is being taken up with domestic things like that, the quality of paying attention to the residents is diminished. And I know that sometimes that people, especially if they have dementia or something, feel very, very lonely, you know. And this is just something, my perceptions of this. And, yeah,
I just want to let you know, we did hire a full-time housekeeper. They are currently working at the hospital, and once her position is filled, she'll be moving over to Lakeview Gardens full-time.
now, is that a shared thing for both cottages?
Yes.
Yeah. You know, we do not expect the CNAs in the hospital, and my husband has received wonderful care. But we do not expect the CNAs in the hospital to be doing domestic chores for the patients there. And I don't know how we can do that with the CNAs in these cottages. So if a housekeeper is coming, that is wonderful. And because there are blinds that need to be cleaned that have not been cleaned. There are floors to be swept that have not been swept. And even though if you're running a mop and your buzzer goes off and you've got to run to another resident, you don't have time to come back and finish that, because if it's a two-person assist on the potty, you know, you might not get back, okay? So I just think some of these things are fixable, and it might take a little bit of money, but it all starts with having that RN full-time in each building, 24/7. And then there's always somebody there. The policy of going to the emergency room, I had an experience that, or my husband did, where they wanted him to go to the emergency room to be assessed, and because he was a do not resuscitate, they did not want him to come. All they wanted was for him to be assessed. He lost 4 days out of his life during this time. I know an incident report was filed, but nobody ever got back to me on that and everything. But I personally feel that the nurses that were working on this and the CNAs that were trying to get him help were totally ignored. I was in bed trying to see a doctor myself, and I rushed back as fast as I could. But what is the policy for these people? You know, when they go to the ER, are they not to be seen? And then if you go in an ambulance, you are to be seen. You know what I'm saying? And then how do you get back? And I know from personal experience in being trustees for other estates and everything, that a lot of times hospitals send you back in a cab. Well, we don't have cab service, and if you're on a gurney, how are you going to get there in the wintertime? You know what I'm saying? So I don't know what the answer to that is, but I think the families need to know. We can't have these people rumbling down the sidewalk in a wheelchair in the middle of the night if they've had a head injury. Do you see what I'm saying? But there just needs to be a plan, and then the families need to be notified of that plan. I think that's what a lot of people are asking. And my feeling has always been that many things are solvable if we communicate with each other. It's when we don't communicate that you don't know what our needs are and we don't know what your expectations are. But for the price we are paying, what are we getting? And I know that is an issue with people because we all got letters that's going up $55 a day. And for what? You know, what is happening there and so forth. And so, but if we just knew the policies when you went in and what the expectations were between the hospital and the Lakeview Gardens and the families, what are all of our roles in this? Do you see what I'm saying? I mean, I hope that I'm being clear on that. And I just think that we're in a position, we're hiring new doctors and everything. It would be great to have, because we're all getting old, me included. I don't like to think of that. But we might consider looking at a good geriatric doctor that would like to work with old people and that would be available to the cottage people when they need help immediately, so that they don't have to wait so long for a response from the doctor's offices and everything. Now that is just an idea I have, but I do think that there are a lot of people that are in long-term care that would like to see a doctor more frequently and how do you get to see your doctor if it's just once every 60 days? You know what I'm saying? And maybe a geriatric doctor would have time to go on a regular basis and communicate with the people. I hope that, that's just my idea. And how do they get to see a doctor, and who decides that? The families really don't know. And I think a nurse in each building, 24/7, could help communicate. Families come at different times of the day. You know what I'm saying? Or people who are their advocates, or whoever's in charge, their guardians or whatever. But they need to have some kind of communication back to the doctor. What was that lab test about? And goodness only knows that one of the things that I'm looking for is respect for the people from long-term care on the side of the hospital and the doctor's offices and everything. These people are very well trained. So many of them have a passion for working with older people, and they would like to be able, if a person needs their hair combed of a morning, they can't, maybe the person isn't available at 8:30 to have their hair combed because they're on the potty, But there has to be some kind of a way that these people can have their residential care and not have all these added responsibilities. And another thing is that I've noticed, and I know everybody's very conscious of the HIPAA Act, and everything, but everybody's working on a computer right out there in the open. If I want to know something, I'm nosy enough to ask about it, But, they don't really have time to work on it in a manner in which I think that they're probably supposed to close down the computer and then go back and everything like that. But maybe there needs to be an area where these computers are that they're logging in that people from the public don't walk past and see. That's just something that I think. I know that we have to look at people that need two-person assists, and that's why another thing I think is very important to have that nurse in each building, because that nurse could be covering, some areas that needs to be covered also. And also could stay up with the meds and everything like that. Because as it is now, the med person's in one building and might be needed in another building to give an aspirin or something like that. I just think that this would help make a success of the gardens. And if they could just have a nurse in each building and have that's readily available to the doctor, to the emergency room, whatever happens and everything. But I want there to be mutual respect from the hospital side. That's what I think. And in talking about food and things like that, there is an issue. And I know they're trying to work on that. But there are people that have special dietary needs. And are they being met? And who shall decide that? Everybody can't eat the same thing. And they didn't in the old building either. They controlled that. My husband was a cardiac. Okay, so he was on a cardiac diet, but he had things that he could choose from, but he didn't eat like some of the other people in the dining room. He didn't have that option. You know what I'm saying? And so, who's monitoring that? And, if you're a diabetic or whatever, that needs to be addressed too, because there'll be new people coming in all the time, hopefully, And I think we have to watch things like that, and I know the service providers, such as the beautician or something like that, or somebody that comes, that they might have some ideas that would help their areas also. I can't speak for them, but I just know that asking questions and communicating, we can work together to make it better, to make it work. Because as I see it, sometimes when people are falling and everything like that, we have accidents waiting to happen, and I would really hate to see a big lawsuit or something like that. And I guess as a citizen and a taxpayer and everything, I want to see this work. We need long-term care. We need affordable long-term care, and we need to see what we can all do to work together to help, you know, to do this. So I hope that you have received this in the spirit for which it was intended, you know, which is what can we do to help you? And we really would like to know where the funding, I mean, where is our money going? What are we getting from that money? Okay? So do you have any questions?
I'd make a comment,
Yes.
and it may not be working, but the model of the cottages that we studied was to add the cleaning chores, the light cleaning chores, to the CNA staffing, so that instead of hiring cleaning people, we could hire a little more CNA staffing. That was the model that we were focusing on.
Well, you know, and models work great and maybe in some communities, but here's one of the things that, as an old teacher, I'm concerned about. And that is that when you have CNAs trying to clean bathrooms and working with chemicals and everything, it's on their clothing. Yes, they change their gloves and everything. But then somebody who has asthma or something, you're going into another room and everything, you've not changed your outfit or something like that. We don't ask the people, the CNAs in the hospital to do that. So why are we asking them to do that? And I think that this cross-contamination is going to be a problem at some point for someone. I don't know if I'm expressing myself right or not, but we can't always follow a model. We have to try and see what works for Lakeview, I think.
Yeah, well, this was working other places, that's why we looked
Yeah.
at it that way.
Well,
It may
and-
not work here, and that's,
Yeah,
I don't know
and
how
that's
they're doing.
just why I appreciate your listening to me. It might not work here.
Right.
And at this point, I don't feel that it is, but I want a model to work. You know, I want something to work here that makes it so that we can retain our elderly here in this community and that they do not feel they have to go elsewhere.
One of the things behind that concept was that the CNAs or the people doing the caregiving would have more contact with the patient or the resident, so that resident would feel more comfortable having the same person there at the same time every day, developing a better, more family feeling and more rapport.
That doesn't work. That doesn't work, and I can tell you, there is no set time. If somebody on one side has a problem and they have to go attend to that, and then somebody has another one, they're not going to clean the room at 9 o'clock. They're not going to do the hair. It's impossible. And I just think that we need, I told Larry this once, and I think he thought I was a little hokey or something, but you know, there are people there, and I know these people from having worked in the community, that are lonely in their mind because they are separated now. They're separated in 2 buildings, so it is very difficult. What has happened to my friend, you know? And so, you know, they say, well, you can go over and visit your friend, but it's just like the nurses and the CNAs and everything trying to run between buildings. You know, there's no heated walkway for the winter or anything like that. And I think that somebody is going to slip and fall, and there's going to be a major accident, you know. But these people they like to be together. You know, in the old place, they like to be together. Now they're not sure what's happening. And so if they're cleaning rooms, they don't have time because the bell is ringing and they need to be elsewhere. So that's maybe another thing that won't work here in Lakeview. And maybe we should consider that what we have to do is look at something that will work here. So it's just my idea, you know,
We're trying to
whatever.
Like a home, like it's
Yes.
inviting, you want to come in. So maybe we have to do more with the common areas and maybe we have to do other things. We are on a kind of a shakedown cruise right now.
Right.
And boy, your input is really helpful.
Well, you know, that's what I intend it to be, because I really and truly, and I think most of you know me, you know, I'm a real advocate for the hospital, and I'm a terrific advocate for the long-term care, you know, but I want to see it work. And so what can we do to help you all to make decisions? We're happy to give, I mean, I'm happy to give input, communication, or anything like that. But I do thank you for getting that one piano over there. and you know what? That is a social activity. And on Sunday when they're having. But we need two more. One that you're going to put in the assisted living and one in the other cottage so they can have services too. And people can come and bring their piano students or their vocal students and everything. We need that. They need some stimulation like that. But I just know there are people out there that have spin-it pianos, not uprights, but I just know there are people who would donate if we put the word out and they wanted to get rid of a piano, you know. Yeah.
I chose the home that the piano is in because I met with the Ministerial Association who volunteers our services. Their service is to do a service for our residents, and they weren't going to do it in all the homes. So I put it in the middle home in that our plan is for all three homes to come together on Sundays, all that can or will, to have a service.
Let's
do that in the
do this.
snow.
Let's have everybody make their comments before we get into the.
Well, I just really, I appreciated the piano going there.
Yeah. Lauren, do you have any further comments for us?
Oh no, I could go on and on, but
okay.
I go on and on. No, I do think, because the day after Mark passed away, I got the mail and where the fees are going to, the daily fees are going to be raised $55 a day. Why?
Yeah. Well,
And I that's exorbitant.
okay.
And that is just my humble feeling.
We'll be going over that in our
Okay.
finance times and then.
Okay. All right, and maybe people, I don't want to speak for everybody, they might have other ideas or something
We're on a
here.
shakedown cruise. Are there other comments?
Yeah, I have
Yes.
some. I'm in the same position that Lori is in the sense that I want to see long-term care succeed. I have a mother who's living there. I had a grandfather who died there. God knows, I'll probably end up there myself. So please get it together now so it's ready for me when I'm there. But here's the deal. Those of us who transitioned over there had a mindset of what we had when we were here in the hospital.
Yeah.
We came in the door and we were in the hospital. And there was a comfort knowing that if there was an emergency, that there was all these resources available to us. Well, now we've been picked up and we've been put somewhere else, and there's no comfort. And there's also been no communication about the systematic way in which you're going to address problems. My mother has fallen several times in both facilities. And when she was on this side, they put her in a wheelchair, took her to x-ray, did her thing, took her back to her room, put her in bed. But this last August, when she fell, when she was unattended in the common area, she fell out of her wheelchair, which is quite a feat in and of itself, hit her head on the ground. They in fact called emergency, and he called 911. How did they bring her home? In a wheelchair with an umbrella to protect her from the sun. That's not what I want. And I don't think that's what I expect. It's not what I expected when I brought her in the front door. So you've changed the environment, but you have not changed any communication with me as to what my expectations are. In addition to that, I hear you say that you think that CNAs can do a more diverse set of tasks, but we have fewer CNAs. We don't have more, we have fewer. We have fewer nurses, we have a half a nurse. I found myself literally this last weekend in search of somebody to answer the call bell. I left my mother in a compromised position. I went out and I could find no one. The nurse was in the other building. I don't know where the med nurse was. One of the CNAs was on lunch, and I don't know where the other one was, but she might have been with a patient. That's not what I expect. I expect to have resources, particularly when you've got a call on. I mean, if the bell's been pulled, how long do you have to wait? That's what's going on over there. And it's easy to say on a piece of paper, well, you have 2 people here and you have 2 people here. But when those 2 people are caught up in situations, they can't cross over and abandon one for another. The facility itself does not lend itself well to either privacy or, interestingly enough, community. Because of the way it's set up, all of the noise emanates from the center of the building and blasts out. I mean, it's just amazing, the acoustics in there, what you hear and what you can't hear. But at the same time, you can't see where anybody was. In the old building, when we were over here, at least you could step out your door and look down the hall. You can't do that anymore. You can't find people. There's a board now that's been put up and says, you know, phone numbers for people. But if you're in an emergency, I'm the client. I shouldn't have to pick up a phone and try to call somebody to come and help me. I mean, that's the wrong way around. There's something upside down with the situation. Cleanliness is a real issue. I mean, it's easy to say that CNAs are going to do these things, but if they're busy and they can't get to it, they can't get to it. Sweeping the floor has got to come after taking care of a patient. I mean, there's no doubt in my mind which one is the more important. On the other hand, if you go to somebody's room and you sit there day after day and you see the same Kleenex underneath the bed, wadded up for 5 days in a row, you go, what's this? Do they ever sweep? Maybe not. Do they ever wipe the blinds down? Maybe not. Do they do a good job with the laundry? Probably not. There's some real process issues that need to be addressed. But the biggest one is the safety of my mother and all the other patients. They're isolated. They've been put into, in my opinion, in solitary confinement. They're stuck in their room. They can't get out. They can't go to the other building for Sunday services unless somebody pushes them over there. Who's going to push them over there in their wheelchair? One of the 2 CNAs? The person who's supposed to stay in the building to be there when somebody needs them? How are you going to get people back and forth? How are you going to do that in the weather? Weather's coming. It's going to rain, it's going to snow, it's going to ice. And these are people who like to be in 75-degree temperatures. You're going to take them outside to get to the piano for the church service or the Christmas tree or the whatever. I don't see that happening. I see what happening is if you're in this building, you do what's in that building. If you're in that building, you do what's there. But the twain don't cut across. And what about our service people? What happens when the nurses are running back and forth between buildings and they slip and fall? Then what are we going to do? This is a serious issue. I mean, we have ice issues in Lakeview. We all know that. And we have big ice issues. We're going to have big ice issues out there. I worry about that. Now, my mother happens to be a do not resuscitate either. In my mind, that means when a doctor has judged that they are dying at that moment, a doctor has said they are dying, then that means you don't resuscitate them. It doesn't mean that a CNA or a nurse sitting over across the street says, oh, this person's dying. We're not going to do that. We're not going to call 911. I expect my parent to get the same care that I would give them if I was there. And until somebody has said, we have reached that point in time. And that's a big issue. I need you to tell me as the consumer how you're going to approach this process with your clients. I'd like to know, because you've never explained that to me.
I'm Anna Marie Dent. My dad's in long-term care, He's been there short of a year, and both sides. He was happy here. He was well fed, had friends, had a girlfriend. Life was perfect. Anyway, when he moved over, he just became really lost. And because he has Alzheimer's and he's senile and has a problem hearing, he took all of his friends away. Nobody talks to him. He's lonely. He is so lonely. He was in tears yesterday. And I go more now than I did before. It's lovely going over there. I love it. My biggest concern is my dad loves to eat. And the food has been horrendous. I mean, they give him pieces of meat that are, you could skip stones with them. I mean, they're hard. It's awful. And I've advised they need to cut it in smaller pieces, make it a little bit softer. And every time I've opened my dad's closet, there are dirty clothes hung up. Now, if they're not going to do the laundry, let me know. I don't want my dad in dirty clothes. He takes pride in the way he looks, and he's not looking real good lately. And I mean, if I'm supposed to do it, I will, but I think when Oregon State is paying the amount of money they're paying for him to be there, he should get 3 meals a day, and he should have clean laundry and a clean room. And being an ex-housekeeper, his bathroom has just been, well, it's a room where you don't have to hit the toilet, thank God. But it's still, you don't overlook that. And I don't think TNA should be doing house cleaning. I just don't. I'd rather they do what they're good at. And to train them to do otherwise, I think is shortchanging them and anybody else that needs their care. That's all I have to say.
Pat?
Pat Saban. My mom was in the nursing home, both areas, over the past couple of years. And so I'd just like to make a few comments, some of which have been touched on already. But I want to say that it's a nice facility. I don't think it was particularly put together with the best of planning, and maybe, in my opinion, there was some lack of common sense in doing that. When my mom went into the nursing area, long-term care down here, you know, it was a nice facility. And again, it was an area where if there was a problem, they could be expediently put into the hospital, taken care of, and I think that was a big plus. That certainly doesn't exist down here. I'll go into that just a little bit more. And the other thing I feel is really lacking, and it's been touched on already, is really the lack of the social aspect that existed over here. People were all put in there, and it's really just not set up because they're not all together. My mom loved that part of it, probably to the point where she was a bit of a pain in the butt, but you know, she loved that part of it. And she could get out, and I think other people did too, where they could associate with other people there, and that was a big part of their life.
Yeah.
Because they don't have much of a life in there, as you guys probably already know. The loneliness is a big issue, but if they can get out and be with other people out there, you know, it goes a long way toward helping them out mentally and psychologically. So it's really missing over there. The meals have definitely gone downhill. It's beyond me how the hospital can spend all the money remodeling, all the money refurbishing the old nursing area, yet can we put in heated, covered walkways between the hospital and the various facilities down there? No, we can't seem to do that. And it's beyond me why that was not put into the initial planning. When I went over there on a Saturday night at 6:30, the last time my mom was in there, I got in there, the CNA was trying to comfort her. She had acute pain on the right side of her head and down the right side of her body. I've been around medical stuff enough to know that it could be a critical issue. And I demanded that they transport her to the hospital ASAP. The first thing that they had to do was get a blood pressure. The LPN came in after I raised a bunch of noise with regard to that. Finally got her in there. There was no RN, and that's another thing that's lacking that needs to be there. She comes in expecting the CNA to get the blood pressure reading, which she couldn't get for 20 minutes. From the time I walked in there and requested transport to the hospital, it took an hour with the ambulance to come, fill around. Couldn't even get an okay for the ambulance until we had a blood pressure reading. Well, I've taken a lot of blood pressures in my life, and it doesn't take 20 minutes to get a blood pressure reading in there. But I will back up and say that all of the staff that I have encountered over there have been very kind. They have been really nice to my mother,
Absolutely.
and I appreciate every single one of them. And I don't know if it's just a lack of staffing or an improper staffing, but I think there needs to be some changes with regard to that. Spending and cost has already been addressed. I know people that I have talked to down there that have been getting the same private care that my mom got, and yet there was a big $3,000 discrepancy in the amount of money that people were paying for the same care. Now, in my opinion, when I put a crown on a patient, I charge them all the same. They're getting the same kind of care. But obviously, that isn't what is happening or what has been happening down there. I've got a problem with that. Seeing as how this is a community-supported hospital, don't everybody that getting the same private care, shouldn't they be charged the same thing? They're getting all the same care, theoretically. I don't know, it's been my understanding that you can't put two people in a room down there, yet in here you could. I guess I don't know, maybe there's some good reasons behind that. A husband and wife evidently can't go in and be in the same room. I don't understand that. I guess that's all I have to say.
My name is John Flint, and my mother's been in the facilities here for a little over a year, and I agree with what Lori said, Indiana, and Pat, totally. On the sanitation, the food's marginal, and the care is lacking. My mother laid on the floor in her bathroom there about a month or so ago, and if it hadn't been for Dorothy Howard stopping in to see her, I don't know if anybody would have found her. And she was laying on the tile floor, gash in her head, blood all over the floor, and they called me. I got there, she's still on the floor. And I asked, there was a gentleman there, and he's a really nice guy. I said, let's get her off the floor. We can't touch her. We can't touch her. Finally, the ambulance shows up. We take her to the hospital, and they go in there, and Dr. Lee puts her back together. He leaves. Here's my mother sitting there. How are we going to get her back to her room? We don't know. That's not our problem.
Yeah.
So my daughter gets a wheelchair. We got it from the intensive care. We wheeled her from over there back to her room. That's unacceptable for $14,400 a month, or $12,400 a month. That's nuts. I tell people what my mother paid in the old building was $12,400 a month. She had a private room, and I appreciate that fact. We've all got private rooms down here. And I was visiting with other people that are residents, and they were paying substantially lower than I was. Well, I went to Larry. Larry and I had a visit one day. And I think I did the talking, he did the listening. And I did get a reduction. But we're, like Pat said, we're all on the same level down here now. We've all got private rooms. And I don't care if the state's paying for it. We're private pay. We're like Lori, and I'm sure there are quite a few others.
And that's what we were too.
But we could go on a cruise
Yes.
for what we're paying to stay down here. And get 3 meals a day, get your room cleaned every day. And I'm sure you folks are gonna work on this, because you better. You better get up to speed. And my concern is I want my mother out of the room she's in, and we've been kind of jockeying with that. But I don't know how you're gonna open that third house if you can't take care of the 2 that you've got.
I agree.
You're understaffed, and there's work to be done, folks. Lots of work to be done. And I think the lawsuit is right around the corner. And somebody's going to take us to task. And there's been a few times I thought about it, but I got over it. But I'm not going to say anymore. These people did a great job of saying exactly what I thought. But you got a lot of work to do, folks. A lot of work to do. Thank you.
Is there any other public comment? Okay, so we've got our, like he says, we have our work cut out for us. So we'll,
If it's all right, what we would like to be able to do, because you brought up a lot of questions, rather than spend tonight, because it is a board meeting, is it all right if we schedule a meeting in 10 days or so
Right?
to
Absolutely.
answer and address these questions? Is
Absolutely.
that fair for everyone? Is everyone okay with that? Because they're important, and we do want to, we have lots of answers, we can address them, but this, we'd like to have them in a way that makes a lot of sense. Is that all right?
I just think that that's communication is what we need. And I think that if you do that, and we can all keep, we want to be advocates in the community. And we want the people who work in long-term care to be respected. And we want them to be respected on the hospital side, in the doctor's offices and everything. When there are needs, they need to get back to them. That is another issue and everything. And I guess that's why I keep thinking, niggling in here, that a good geriatric doctor, maybe would be on call to help them, when they have a need. But we have to take care of our staff too.
Yes.
And we have to speak up that and it's just like everyone has said, and I think they all feel this way. When it isn't the CNA's fault, when they're with a person and they get a call for another person, and you have to leave this person on the potty and say, now don't move, I'll be back, and there are people who just get up and go, That is where there is a real problem. And it isn't that they're not doing their job. They just we need more help, and to keep the people from feeling so isolated and lonely, we need to work on that. So I think it would be a wonderful thing if you want to involve any of us again, that would be great. Because we want this to succeed.
should be a public session.
Right, and I sincerely hope that you from where I'm coming from, we need this in Lakeview, and we want it to succeed.
And we're
So
all
my
getting
message is, what can we do to help,
Well, and in the meantime, I'm sorry, my name is Jennifer McDermott. I am Lori Crocker's daughter and Mark Crocker's daughter. And I've spent a great deal of time coming down over the last several months that Dad has been in long-term care. One of the things that strikes me as fascinating is that we have all these travel CNAs, and they're terrific, every one of them. But when you move them into the house and the cottages, word gets back to the companies that they work for, what the level of treatment is, what the care requirement is that you have on them. None of them want to come back, and why would they? They don't get to do the thing that they are really good at, which is being with the people that need them the most. You cannot just pretend that these people, because they're old, that they're disposable. And that's what I feel like. And I don't mean to be contrary, and I don't mean to be nitpicky. There's nothing worse than getting a call and knowing that your dad has fallen. And I knew when he moved into long-term care what the longevity of him was. It makes it more complicated. I could have had a couple more months with him maybe, and maybe that would have been better. I love my dad. I love this community for all of the people that are here. But the way that you're running this particular portion, it doesn't need a model. And I'm tired of hearing words like shakedown crews, because that's crap. And all of us know it. All right? You cannot experiment on elderly people. You cannot experiment on the families that are also lending their voices, their money, everything that they need for those that they love and that they care for. They cannot, okay? Billy used to come in the room and talk to my dad every night, and she became depressed once they were separated. Okay, and those relationships that they make, are the things that keep them solid and grounded. They may be talking about breaking free and going and having a dance. Let them. As soon as they get up out of their wheelchair, the tattler's going off, so they know they're not going anywhere. But that communication and that land that they're in and their mind needs to be functioning. Idle minds kill people faster than anything else. And when you separate people from one another, they will die of a broken heart. And that is not okay. Please listen to what these people are telling you, because I don't want to come back to this. I don't want... Every one of these people, when I was a child, lived here. And they supported me, they supported my family, they supported this community, and they support you. And they deserve better. Please do something that's better.
Okay, do we have a date?
We'll set that up just as quickly as we can and let everyone know.
Any other comments? If not,
I really like to thank everybody for coming this evening.
Thank you.
Thank you.
Thank you for listening. You know,
Appreciate
it's
the comments,
important
and
for
we
us
will-
to be heard.
as
Thank
John
you.
says, we will
Vincent,
address the issues
V-I-N-C-E-N-T.
and we'll be working at it. We apologize for the pain and anger that we may have caused. We didn't do it on purpose.
Of course not.
But we're, miscommunication, pain and anger, and a little bit of money thrown in. We're going to work at this, and we're going to make it work.
Right.
Thank you.
And we want it to work.
Yeah,
Yes.
we're
That's what
getting
we
old
want.
too.
There's a lot of
Yep.
layers to this onion, so we'll be working at it, and maybe
Yeah.
there'll be a few tears along the way.
Super.
Hopefully, they'll just be mine.
Thank you.
Okay.
Okay. Thank you.
We have some executive action.
Thanks. Thank you all so much. Listening to us. Thank you.
Good night, Larry. You didn't say a whole awful lot, but I heard it. Yep. Thank you, John.
My phone went off and everybody's phone went
Okay. The second item on our agenda was Lakeview Gardens, but
Right.
we jumped ahead.
Right.
So.
Just on, I see that we have the Lakeview Disaster Unit here. Do we want to jump to any issues with that? Will that, rather than
Can
have to
we
wait?
talk in public, or do we need an
No,
executive session?
I don't think there's anything. We're just here in case you needed us.
Oh.
Over
I'm
the
not being carried out
employee.
yet.
Well, actually, you're involved in this issue too.
Yeah, you're part of the solution, the volunteerism in this community, for the transportation aspect and things like that. You're part of the big volunteer community. And, if we had more volunteers, we'd have fewer problems with transportation, for sure. But that's a side issue, and that's one of the things we're grappling with now.
We work on it night and day, so.
Yes, you do. Yes, you do. Okay. Let's go to Lakeview Gardens, and then we'll do the consent agenda.
You want to do financial?
Well,
Should we do financials, or you want to do all that at one time?
why don't we do the consent, let's scrap that Lakeview Gardens there, number 2, and just jump to the item number 4, approval of the consent agenda.
I'll move approval of the consent agenda.
Can you hear a second?
I can say.
Okay. Okay. Moved and seconded for approving the consent agenda as presented. All those in favor? Aye. Opposed? Hearing none. Okay, the August 2017 financial report. Cheryl. And I haven't had a chance to review those. So you had the auditor here, so you had to,
Wow,
yeah.
all right. But don't push this button on there. Okay, little pointer for you.
Nobody's there.
Try not to. We have any toys, I had to teach it.
You have to be exclusive.
What?
That means don't come to me.
She missed she went to the meeting, but we didn't have one.
Oh, that's okay. I was just saying that things have to be exclusive. We have to also add a line that says that means don't come.
They own.
I was gonna start. Yeah,
We had a great conversation
We had a
though.
great conversation.
I will put that in my brain for future reference. Okay, so, we did have the auditors out here last week from Whiffley. We had 3 of them here for 4.5 days. We scrambled to prepare before, obviously, they send you a lengthy list. I meant to send that to you one time so you guys see what we're putting together for the auditors. I might, just because it is pretty impressive. So, anyway, the audit, it went pretty well. I really was pretty happy with the way things went. Challenges last year, this year should be a lot easier, and I was grateful. And I was glad that we put in all the extra time that we did, because it did, I feel, pay off. I think another thing to mention, because it's always an issue, is Charlie and I had a lengthy conversation with the auditors on their way out the door. And they pretty much said that we're not going to get our audit before January. And I guess my takeaway from that is because they just don't have that many resources, and they take a lot of time off in December. Did you get that? That's just
Well,
what he
the
said.
partner-
That is what he said.
The
The
partner takes
partner
the
takes a
time.
lot of time off.
So remember, once the audit is done, because it's a public entity, it has to be signed off by a partner that has public entity signing capability. And that is, I think, one within the entire,
Organization,
well, for this part.
or, well, yeah, you're right.
Ripley
We're
from
Pacific
west of,
Northwest.
yeah, their main offices are Minneapolis, but out here's one guy, Jeff Johnson. And so he's,
So it goes through our partner, Eric Volk, and then it goes to Jeff Johnson. So regardless of how well we might have done, we're still not going to get our audit before January sometime. So,
they also volunteered to contact the bank, make sure, because we said, you can't do that. And they said, well, we'll explain, we'll give them all of the information, but it just won't be a finalized report as done by the signing, the public entity signing partner. It'll be otherwise completed. They will get our cost report by November 30th. It'll probably be on November 30th. But it'll be done.
it probably will, yeah.
But
Okay, so then, looking at August, August was a better month than July, but we still are looking at a 7% decrease in hospital patients year over year. The bright spot is down here in ancillaries. Our ancillaries are up both for the year and for the month. So we had a very big month for lab and radiology and for rehab. Home health plugs along, and the health clinic had a very good month with over 1,000 patients. So that's good stuff. This is our patient charges for the month. The charges for the month were just over 3 million. It's our second month ever that was over 3 million. That, of course, was driven by the ancillary services and also by surgery. Mostly orthopedic surgery. This is the collections on our AR. The current month is right here. This is August, and August came in right about $1.8 million, as did September. this is one piece of information I can tell you about September. So those numbers at 1.8 are better than our average for last year. They still are a little bit lower than what I would like them to be based on our revenue numbers.
Quick question, you were talking about surgery being a plus, but if you looked at the departmental, our budgeted surgery was much higher than our actual revenue. Did
And
we
I think-
over budget or what?
No, I think that the way we budget is, we kind of just, maybe this is one of the times when I probably should have weighted the revenue towards the end of the year instead of the beginning of the year, because she is definitely building. She's not, I'm sure that her months at the end of the year are gonna be quite a bit bigger than her months at the beginning of the year. So as far as I know, she's had nothing but positive results and response from people who go for, just appointments, as well as people who get total joints. So I would expect that she's gonna build over time. And you're right, we are.
Year to date, you just divide by 12.
Yes. Because for most things that we do here, that works really well. I didn't like it at first, but to be honest with you, it just works for this hospital. We're very static, month to month and year over year. This is a different kind of thing, so.
Well, I'm thinking of what date is Mary having her,
November
6th, I
The presentation to the Rotary Club,
No,
no,
here.
here.
Her clinic.
oh, it's in November and.
It is going to be November, it's either the 7th or the 8th. I can verify that and send that out to you.
Thank you.
Yeah, I probably should know.
To talk about total joint.
Community briefing, educational outreach, yes.
Okay. So based on our collections, our days in AR went up a day, so we're not happy about that, but we're still staying close to where we are, and Lisa and I are working on some specific things that we hope will bring this down. Okay, this is our line of 90 days where we need to be above. And for this month, we are 1 day below that line. We're at 89, where we'd like to be 90. The days cash would have been 108. We were sitting on a $900,000 bond borrow that we did in September, as well as a lease that we signed with GE that finally funded in September. That was $300,000. So that should be better in September. Okay, so here's our profit and loss for August, the month of August, as well as year-to-date now for 2 months. Our net revenue was $187,000 below budget. So again, it goes back to 2 things. I do expect our revenue to grow over the years. We did have contractual adjustments were very high this month. And really what that means is we got more payments from Medicare than Blue Cross. It's kind of, it's not something that you can really predict or control. It's just, it is what it is. We had high contractual adjustments, which lowers your net revenue. Our salaries were below budget, $144,000, because we haven't hired or grown, as we anticipated quite yet. Employee benefits was very high based on salaries for 2 reasons. One of them, we had an audit on our life insurance. We had a rather large payment on that to make up for, they haven't audited for a couple of years, so it was ugly. And then we paid our annual early fee, which, so this will go back down to a more normal expected number next month based on salaries. Materials and services was pretty high, given that revenue was high, but it's still below budget. The other thing that was different this month that kind of hit us is we did not charge Lakeview Gardens for rent again, because it's not done and it's not all really ready to go. So there's a difference here in non-operating income, which is the rent that I did not record. That's what most of that is right there. That seemed like the right thing to do. Year-to-date then, so we had a loss for the month of 16.8. Brought our year-to-date loss down, or gain, down to 104. So we're 80,000 ahead of where we budgeted to be net after our first 2 months. Balance sheet, our current month is a little bit darker. Really no big changes. Our cash went down. Our AR went up, which, why our days in AR is up. Our fixed assets are up a little as we're booking invoices on the clinic remodel. Right now, we probably won't borrow on it until we get to around $1 million, since it costs us several thousand to do the borrow. So we'll do that same kind of cyclical thing, although the invoices are quite a bit smaller. Liabilities went down a bit. Really, the net change month to month is only $280,000. So really nothing going on there. Questions on Lake Health District before we go on? Lakeview Gardens for the month of August was at full capacity, so basically 100% nearly, not quite, but almost. Our revenue for the gardens is this number right here. It was $211,000, which is much more reflective of capacity, the number of patients, residents that we had than anything else. And this is our profit and loss. So revenue for July and August was very close to the same, but here in August, you can see that we are ramping up training employees and starting to get ready to move. Again, contract labor was $55,000. We did anticipate at this point that we would have more permanent full-time staff and less contractual labor. So this number right here is really, really hurting us. Other numbers are kind of in line month to month, nothing very outrageous. So all in all, this caused a loss of $68,000 for the month, which is really a lot about the wages. The balance sheet, really, their cash went up a little bit, their AR went down, their debt went down a bit. Again, nothing really noteworthy here. Goose Lake Medical is, as you know, struggling with the loss of a doctor. We've had a few locums. I'm sad to tell you that a couple of them were not well received by the community. They're not here anymore. One of them was very well received by the community, and they are dying to get him back, so we're trying to get him back. But the problem is then our revenue goes way down and our expense goes way up because we were paying for those locum doctors. So now our year-to-date loss is $74,000. We lost $41,000 in August. Balance sheet, no changes. Their AR is steady and it's high, and their liabilities grow as they lose money. Okay, and Lake Health Medical Supply. They have achieved a point at which they have enough oxygen clients that we should not have another losing month. So they had a net profit of $3,000 this month. The oxygen patients should sustain them, and the rest will hopefully continue to grow as time goes by. Questions? Yeah, I like that.
Here I sit.
You're up.
I'm up. Okay, medical staff privileging.
In the absence of Dr. Gallagher, our chief of staff, we have, I believe we've sent out to you the recommended reappointments or new appointments. Pretty straightforward. The medical staff reviewed these and recommended to approve these additions and renewals to the medical staff.
So moved.
I'll second that.
Been moved and seconded to approve the medical staff privileging as presented. All in favor?
Aye.
Passes unanimously. Community health needs assessment.
Is a requirement for all hospitals, and especially all critical access hospitals, that we do a 3-year needs assessment of our communities. And this was expanded on as part of the Affordable Care Act. So when we started the CHIP program, if you recall, in 2013, that was the beginning of our needs assessment. So what we did was we gathered a lot of information about Lake County, and we held focus groups with members of the community. Some of you may have been at those meetings where we asked a lot of questions, and put dots on the wall and said, what do you think is the most important? And so what that does is, and there's a process for going through community health needs assessment. And so we did that in 2013. We have updated that. Most recently, we had in August or July a community forum where we asked similar kinds of questions. Have the needs changed, and how do we want to redirect some of our energies toward improving the community health needs? Now, this is different from a normal hospital operations. This is where we're getting involved in population health. So we look at things that, as a hospital, we don't necessarily think about. This report, so that you know, is on our website. It's available and has been for about a month, and talks about a little bit about the health district, a little bit about the services we provide, our mission, the process we went through to try and come up with community involvement with our needs assessment. And we looked at our population demographics. Now, there are a couple things that are important for us to keep thinking about, and why, as we direct the activities both of the CCO in our county, but the CCO really deals only with the Medicaid population. So we look at the whole population. And our Community Advisory Council, which all counties have to have as part of participating with the CCO. And in our case, there's 12 counties in Eastern Oregon CCO, and all of the counties have a Community Advisory Council. Each Community Advisory Council reviews the community and is involved in creating a community health needs assessment. That, along with our involvement with this, meeting the metrics, or focusing on the metrics that the CCO, which is driven by the Oregon Health Authority, those things that we need to focus on. These issues, what's the age of our population, our racial ethnicity, that doesn't necessarily play into the health needs assessment unless we have, for example, in our racial characteristics, if we have differences of types of populations that we need to focus on. And so that's part of our issue. For Lake County, that isn't quite as, we don't have quite as diverse of a population as other counties do. We've looked a lot at our health outcomes, and unfortunately for us, Lake County suffers with some of the worst health outcomes in the state in a lot of the metrics that we look at. And so a big part of our community health needs assessment is to review these state outcomes or measured outcomes, and then try to create strategies to change that. And again, this is outside of a hospital service. This is population health. And then we work with both our medical community as well as the other, and a lot of this you can't read, so I'm not going to, it is on the website. This information is readily available. But I want you to know that we do have this, and we are working on these kinds of issues. Why do we have, it's amazing. People that are smoking in Lake County is less than the state as a whole. But our binge drinking is higher. And you can see there's lots of other kinds of things that we look at and we have to consider. So Commissioner Kestner left, but we bring up this kind of information at our community advisory councils. And he is active in this committee. And here's an example of a concern. It's really hard to figure out. We have a higher low birth weight rate than other counties. Low birth weight is defined as an infant that is born, if they would have been term, then they would have been 5 pounds. So if they're born prior to term, or that's how they get measured, but it's per 1,000. Well, it takes us 10 years to get to 10,000 or 1,000 births. So one can skew the numbers. And that's one of the factors that play into some of our population statistics. Our cancer rate or our suicide rate or some of the other factors, because of such a small population, it can skew. Just wanted you to see this information. What I would like to do, it is an absolute requirement that as a condition of participation with Medicare, that we do have a community needs health, our community health needs assessment. And I would request that you approve this plan. It has been reviewed. It has been taken to our community advisory council. They approved it. But if you could accept this report, that would be great.
Is there more than data here? Or
It's all data.
It's just data?
Yes. Yes.
Charlie, who compiles all this?
So it's a combination of state data. So a lot of it comes from the Office of Rural Health, or the statistics that are, God bless you, gathered by other state agencies, and then we compile that. A lot of it is gathered through the Office of Rural Health is gathering it for us, or Oregon Health Authority. That's where we get most of the statistics. What we try to do when we have our community input is to see if anyone thinks that either the data is not necessarily accurate, or given the data, we should change our focus and think about certain things more than others. And so, for example, we've talked often about, can we do things to improve our physical health, encouraging physical activity, so that can deal with some of our obesity issues, some of our other chronic kinds of conditions. But most of this is gathered through state-generated data.
So we wrote this.
We prepared this with that data. Yes. Our vendor Singh is the one that has been working on this, and there's a lot of gathering of the data, but used all sorts of other resources.
By accepting it, we're just, what are we saying? Now, I haven't had a chance to look at it, so I wouldn't know whether one was skewed or not. I guess Charlie doesn't mind.
Okay, well, if you would like to look at it, we can talk about it at the next meeting. That'd be certainly fine. I can assure you that we've gone through a pretty rigorous process to gather the data. A lot of this, if it's gathered by the state, it's hard for us to know and to corroborate if it's not accurate, the percentage of food stamp recipients. There's the source, and so that was provided to us by the Oregon Health Authority, or the Department of Health and Human Services with that. So that's how we got there. One of the things that has been happening, and why I was asking that you might approve this, is there are hospitals, especially smaller critical access hospitals, that have been fined $50,000 by the IRS if they don't have an approved health needs assessment. So it has to be done every 3 years. We have met that requirement. I wanted you to know that we have it, and that's the principal reason for doing this. We do meet the requirement.
It's the 501.
That's correct.
I would make a motion to go ahead and approve this report. Let's go back and amend that approval if we need to.
I'll second that.
Okay, discussion?
It's just difficult to approve something when you haven't had a chance to review it for me, Don. That's right.
Well, the motion's been made and seconded to approve with the ability to come back and look at it next board meeting. All those in favor?
Aye.
Opposed?
Aye.
Passes with one in opposition. Okay. Employee recognition. Mr. Quake.
Today, I'd like to recommend someone who turns out she is the lead medical assistant for Chris McAllister. She works diligently and became a certified medical assistant, which is a step up, and is very active with NAM in the Lean project. So one of the things we talked about is the Lean, looking at how do we improve our processes and thereby deliver a better service. NAM has been working with several different areas, and specifically in our clinic, this medical assistant has been very involved, very helpful in that process. She's always willing to assist other staff, goes above and beyond patient care. She offers constructive suggestions to help improve the processes for our staff. Her name is Karen McLean. So, she's our employee of the month.
Okay. CEO report.
Did I close everything by mistake?
Care what you think.
You never know, I might do something wrong. There have been a lot of things going on. It's hard to believe that 2.5 weeks ago, we had our strategic plan. So we talked a lot about so many of the things that we are working on. But just the last couple of days, I'm pleased to say that Tara Guile, who has returned from her internship as a dietitian, where she was at a hospital in Carson City. She finished her program and just passed her test. She is now a certified clinical dietitian. So if you may recall, she started several years ago in the process of going to college, finished that, get into the dietary program, and is now a certified dietitian. So we have, for the first time in a long time, a resident dietitian in our community. So that's really an exciting thing. A little bit on the construction, Lakeview Gardens. We have been in the building, but there were a couple things that still needed to be finished. We had some problems with water, problems with heat, addressed most of those. We are waiting on our sign. The county still has not given us approval to put our sign in. We have the sign, we're ready to put it in. But we hope to have that soon. The landscaping should be finished. It was supposed to have been done August, then September, then October. Detroit had to bring in a completely different crew to help finish this. They're telling me it should be in 10 days, but I'll believe it when I see it. I don't know how we can make it go any faster than that. The clinic is, if you didn't see, they were pouring concrete in the expansion today. They did pour in concrete for the central reception area last week. So it's moving forward. Designs are at the county, at the state. They're moving as quickly as they can on all the issues, and we're addressing them as we go. So, any questions about that construction process as we're going? We had in August the state mandated nurse staffing survey. We were, I believe, number 12 of all the hospitals, of the 60 hospitals. We were number 12 to be surveyed. Not everybody has fared well in this survey process. We got our results 2 days ago, and we're going through the process of ensuring that we live up to the state mandated number of staff that we have to have, and how often do we. Unfortunately, a lot of it is about how many people were in the meeting, how many of the union members were present, how often did we present, a lot of clerical type things. Wasn't necessarily concerned about how many people we had staffed, but we are addressing those. The results were not unexpected as we went through the process. Grants. Do I have the grants? You can show me. A year ago, we hired Christy Albertson to work on grant writing. And she's been pretty busy with grants. And I can show you that these are the grants that we have requested and those that we have actually received. Now, the first set on the top here are predominantly from, for example, the Eastern Oregon CCO. Some of those were determined by region-wide, so it wasn't so much that we had to work hard to get the money, but we certainly have to, once we get the money, we have to do things related to it. The big deal that we are participating in, and we did as a part of the working with prevention, Jake Greer, or not prevention, excuse me, probation office, and with district attorney's office, we have through the drug treatment court, you can see it's about $557,000 that we are receiving over the next, I believe it's 3 years. That helps go toward looking for more staff to help in the drug court. So that's pretty exciting to get that kind of money for Lake County. This is the food share summer food program that we did this summer. And then we have some other grants. You can see that some we did get, some we did not get. Total amount was $832,000. We have pending in year 1, 10,000, and we've gotten a fair amount of that money. So that's a really exciting thing. I think that it's important. Christy's really worked very hard at looking at how we can find other things to support the activities that we're doing. Not all of this is related, and very little of it is related to inpatient care.
Right. Are we getting a little bit of support from the county and stuff for her salary for helping write these grants?
They have not participated in that. So we're working.
Is any part of that funding offset by being able to have the grant writer take a portion?
Not yet, not yet. But I think we're still very new in the grant process. One of the things that happens is once you start getting grants and you show your ability to apply, receive, fulfill the obligations of the grant, and meet all of the reporting requirements, our ability to capture more, and then that would help. We could include in there some of the cost of writing the grants. That's part of the process. So this is year 1. I think we have to look at this as getting that kind of money is not going to happen every year, but the more that we can get that's covered, not only the programs, but also the process of getting the programs. We'll be able to get that. So I think it's pretty impressive what she's been able to do. So that's on that part. We received, I believe it was last Monday, an award from the Eastern Oregon CCO as part of our risk program. I think I told you with the, I don't know if it was at the planning meeting or at the last board meeting. we received actually $400,000 in monies that went against the risk pools for taking on the CCO members. We received a check that if we meet the metrics that, and the metrics being, for example, colorectal cancer screening, we have a certain number of people that are eligible to receive that kind of screening, or mammograms, or their diabetic screening, or other kinds of screenings. If we can get our clinic to, and our physicians to be able to see those people, and we get to a certain, the expected percentage, we can get grants, or we can get awards for that. We received our portion for what we met, and it was $76,000. So we received that amount. Now, we did not hit on all the metrics like we had hoped, so that wasn't quite as good as we think we can get. We left a lot of money on the table. So with NOM's assistance and focusing on, through the lean process, looking at where we're documenting, making sure what we document is billed, because that's, all that is based on what we bill. We're working on improving our outcomes. So I don't know what Dr. Graham and his clinic did as part of their reward, but this is separate from their reward. So that all goes toward helping Lake County focus on meeting those needed health measures. But that was a good thing for us. I went to Washington, D.C. last week. I think you all know that. I had a chance, this was the first time that we met with every one of our elected officials. Last year when I went, we met with several, but not all of them. We met with their staff. It was an exciting time, and I could give you lots of information, but probably the most noteworthy, as I was there on Tuesday, that the Affordable Care Act did not get approved. Whether you think that's a good thing or not, had it been approved for the state of Oregon over the next 10 years, we would have lost $16.9 billion. So our hospital association was quite against it being approved. That didn't go quite well with all of our legislators, but they were still met with us and talked about it. We talked a lot about some of the other issues that we perennially are worried about, going with the potential loss of the 340B program. Helps us in our pharmacy programs. Some of the rules that CMS has that we don't think are they're onerous and they don't make a lot of sense. I can tell you that Ron Wyden was very proud on Wednesday when we met to tell us that they had passed a bipartisan chronic care plan out of the Senate. He was very pleased with that. It goes to the House before it gets sent up to the White House. But his feeling, and actually several of the legislators said, it's a shame that the press focuses on the parts of our world, politics, where we're at each other's throat. There's a lot where we're working together. So that was good, I think. And it's important for us, I think, to have Lakeview and Lake County represented and reminded when we're there.
So as to the 340B, what has transpired?
Every year, the 340B program, Big Pharma that is promoting, or is not really interested in doing this because it takes some of their profits, looks to try and either eliminate it or scale it back. And we encourage our legislators not to let that happen because it does make a big difference. And I believe for the state of Oregon, there was about $400 million that were that those dollars came to the state of Oregon last year. So it has a big impact on a statewide basis.
Does it have to be reauthorized, or is it just a, or is there just a movement every year to deal with?
In some cases, it's a movement, so it could be a CMS-directed change. It doesn't necessarily have to be reauthorized, but it comes up with other legislation. And so, like the CHIP program that's being discussed right now, that's the program for kids. And that, they're throwing things onto it to try and change how that would work. So people add to other legislation that might impact, and we want to make sure that they don't. In the state, from the political standpoint, I have for you, should anybody want to spend time on our political involvement, these are the things that happened in this last 2017 Oregon legislative period. Things that were approved, things that were not. This is online, it is. And so if you want to have copies of that, have plenty of that. Probably the biggest thing that we will be dealing with in the next couple of weeks is the referendum 301. And that is the activity that Representative Julie Parrish is talking about. And she's working to get the required, I believe it's 60,000 signatures. If she does get those, and those signatures are validated, then the tax to the rural hospitals would not be occurring. And it would go for a statewide election or vote in January. Were that to happen, that could potentially cost the state and the Medicaid program about $800 million. So you can imagine that the association's concerned that that would happen. Because the $800 million, the way I think we talked a little bit about, if the state matching program for Medicaid, the state puts up $1 million or $100,000, the federal government matches it 3-to-1, and then there's other additives to that, totally making it about $800 million. So we'll have more information for you about that. That's kind of a pressing thing.
When's the deadline for the signatures?
I believe it is next week. I don't have the exact date, but we're watching it carefully. Beyond that, I can't tell you. One of the things that is exciting and that's moving forward, as we've been working and talking for several years about how we can work well with the Lakeview Disaster Unit. A person has been extended an offer to act as the EMS operational director. That is the person that we would jointly share the cost of that person to help work on how to support the Lakeview Disaster Unit and work to ways that we can work better together. We hope that she will start on the 23rd. That's the planned date. Her name is Kristen Hill. So that looks really positive, and I have no reason to believe that it won't happen. So we do need to deal with, as many of the people talked about, the transportation issues. And we know that, we've known for some time that transportation between the Lakeview Gardens and the hospital for patients, we've got to address that. And so we've got a group that is working on coming up with strategies to deal with that. I expect that we'll have a plan for you and results pretty quickly. So we're actively working on it. Last week, I believe it was, that the Department of Health and Human Services, DHS, Representative Warren Berg was here, looked at our assisted living. Was it last week or the week before?
It was the 26th. Oh, 21st. Yeah,
21st, so a week and a half ago. And we have met all of the requirements. So while we haven't got it in writing, we expect what he has said is there aren't any other issues that would cause us not to be able to open up the assisted living. We are in the process of hiring people so that we can get them in training. Our goal is, if we hire people, get them trained and we get the approval, expect you to have the approval, we will be able to start admitting patients or residents by the week of October 3rd, 23rd. That's our target date, provided we can hire the people. And Larry and Annie are working very hard to find people and get them trained. Talked a little bit about how we've been working on our group purchasing arrangement, GPO. It's really down to two companies, Intelair and Vizient. We did not come to a final decision like I'd hoped for as of the end of September, so we're still working through the numbers to see which one makes most sense. They're very close, as you can well imagine. So we want to, one of the hard parts about it is both companies say, well, I guarantee you that you'll have these savings. Let me show you how it'll be. One's a little more assertive, saying we will assure you of that. But the savings both are promising, look pretty good. So we're working on that, trying to get that. So. That's all I have. Do you have any questions? Oops, what did I forget? Okay, we can talk about that offline. Any questions or issues?
Any questions or
I have a question we could talk about later, but I gathered, and I'm probably wrong, that if you call 911 from over at the cottages and a patient is DNR, that the ER won't take them. I mean, that's kind of what I grasped when it didn't make sense to me.
I think there may be some misunderstanding on the communication of that. And what we want to do is have a clear explanation. Just because a person has a DNR does not mean that we don't provide service. We don't do resuscitation. That's different. So I think that there's a misunderstanding of what that means. But no, we do provide service.
I've always thought we did.
We do.
I was going to retract my DNR.
I will be able to build you more that way.
We'll haul you, Chuck, we just might not break your ribs.
Again, one of the things that we absolutely want to do is make sure that with all of the issues that were raised, whether they were raised tonight or that we've heard otherwise, we want to make sure that we outline them, have clear and succinct answers, and describe it, and then have a public forum talk about it, and make sure that there isn't any misunderstanding, because that's the last thing we want. Chuck, did you want to add anything to our discussion about?
I think, like you said earlier, there's some details that we need to work out as, you know, as long as if Kristen's approved by your board and whatever, that in the interim, before we get that building built, is, you know, what we're gonna do with her use, you know, with the office materials and that kind of stuff, but I still think the 50-50 is the way to accomplish the wages.
And we have every expectation of onboarding her. That's what we call when we start somebody. And the reason the 23rd was picked is she's out of town next week, and it falls well within the starting period. So.
Or to hire them when you're out of town.
Well,
Yeah. Okay. Any other discussions? We'll go into executive session then under 192, 662, bracket A, personnel, bracket C, medical staff, bracket H, legal, and bracket J, property. And Lisa, you wanted to stay?
Yes.
And
Dave and myself.
Dave and you, okay. All you others get to go home. Have a nice evening.